So we're going to start in 1, 2, 3. Let's roll. So, my dear friend, how are you?
I am good. How are you?
You worked all day, didn't you?
I did. I finished, I'm going to say, an hour and a half ago, and it's 8:36 p.m. here.
In paradise, right?
It's, what's that?
I said in paradise.
Oh, yeah. It's been very long days. It seems like we're working even more than before.
So a lot of people already know you, but for the audience that do not know you, do you mind introducing yourself? Tell us a little bit about you, your name, where you're from, your practice, everything. We want to learn everything you can about you.
Okay, well, I'm Dr. Karen Becerra. I am originally from Colombia. I've been living in the US for about 20 years. I am a general dentist. I run a community dental clinic that is created to serve seniors only in San Diego. We have 2 locations, and part of our secret has been to bring healthcare where patients are. And what I mean by that, in our downtown location, we are co-located inside a wellness center where meals and supportive services are provided for vulnerable low-income seniors. In our North County location, we are located inside a PACE program where very frail seniors receive services. In our North County location, we are also open for seniors in the community. We have been in existence for about 4 years now, and the biggest secret or the biggest part of our success has been our very low no-show rate. We have a 5.6 no-show rate. I used to work in community clinics, and we needed to overbook 7 times, pretty much about 35–40% was the overbooking, because transportation was always an issue and patients would have conflicts and could not show to their appointments. So here, a 5.6, as you can understand, tells a lot about some of the things that we're doing right.
Amazing. But before we go there, let's talk a little bit about you. So did you do your training, your dental training in Colombia?
Yes, I'm a foreign dentist. I am a foreign graduate. I went to Pontificia Universidad Javeriana. It's a private school. It's a very good school. And I also did a master's in public health.
So why did you decide to become a dentist? Why?
There were some dentists in my family. My grandpa was a lab technician. Some of my uncles were dentists as well. I always enjoy caring for people and helping them find reasons to smile and feel good about themselves. I am very artistic, so it was like a natural selection for me. It was like a no-brainer. That's what I wanted to do.
How long is dental school in Colombia? Is it hard to get into dental school in Colombia?
You go to school for 5 years, and when you graduate, you have to do 1 year of social service. That is, you work for the government in an underserved area. You get paid, and depending on the risk of that area or how rural it is, sometimes some of those locations may have a requirement of only 6 months instead of a year. That is mandated, and you have to do that social service in order to get your permanent license. Was it difficult to get into dental school? Yes. You have to take the high school test. I don't know how to translate it into English, but it gives you a score.
What is it called in Spanish?
The ICFES. And it will give you a score, and with that score, depending on how good it is, you know that you will be able to apply to some universities. I applied to all the best ones, and I got accepted in all of them, but I chose Javeriana because it's the best one.
And how much did you pay for 5 years of dental school?
Oof, that was a long time ago, because I graduated in 1995, but I don't remember, but it was very expensive. I had to get a loan. It was very, very expensive. It was even more expensive than medical school.
Sure. So what made you decide to come to the United States? And when you came here, did you have to do dental school all over again?
I came to the United States because I wanted to become a pediatric dentist. So I came first to study English and improve my English. My dad's family work in the government, so I always thought I was gonna go back and work in the government. But I came here and I learned that California had a process to become licensed without having to do the 2 years of dental school. So I thought that that makes sense for me. And there was a program here that was independent. So I wanted to apply to that. The only requirement was to have a dental license because it was hospital-based. And I applied and got the license, but unfortunately the program was taken over by UCLA. And at that time, they were not that friendly with foreign graduates. So for me to be accepted, I would have to do 2 years of an international dental program. So I decided that given that I already have a general dentist license by the state of California, I became a general practitioner.
So did you actually have to go back to do 2 years of dental school, or did you practice and you got a...
I did it through exams, which no longer is an option. So I had to take the National Dental Boards, Part 1 and Part 2. And in order to be accepted to take the clinical board here in California, I needed to pass the Part 3 or bench. So I did it like that. Quite honestly, it would have been faster and probably it would have made more financial sense if I had done the 2 years. It would have been better, but I thought this way would have been faster. So that's what I did.
So how is practicing dentistry in Colombia different or similar to practicing dentistry in the United States?
When I came here first, the biggest shock that I thought I saw was that we practice with many columns at the same time. 4 chairs, sometimes 5 chairs. Over there, when I was there, we only practiced with 1 chair because assistants can do as much as assistants can do here. So that, and probably what else was different, the insurance, the system with insurances, that was very different. And also, not anymore, because nowadays I stay in touch with my friends, my colleagues and friends in Colombia. But at that time when I was here in the early 2000, liabilities. We didn't have that in Colombia, the professional liability and all of those things, that was different.
So why do we need it here, and why do we not need professional liability in Colombia? What's the difference?
No, I think now patients are more educated and more aware. So nowadays providers are having professional liability because they understand all the risks. All I'm saying is that we didn't have that culture of liability like it was here 20 years ago when I first came.
So you came here and then you became an associate. Am I correct? You were an associate in some dental practice?
No, I worked first in a community clinic. In fact, I combined my time between a research project where it was called the Hispanic Community Health Study. It was an epidemiological study looking at the health of Hispanics in the United States. It had 4 sites. And dental was there. It received a grant from NIH, and dental was there because of the connection between mouth and heart. So they were looking at why Hispanics, even though had some more risks for some diseases, when they were looking at mortality, the rates of death were not as high, and they were trying to understand what that was. The study is still going on. They are doing follow-ups. So I did work on that as the lead dentist for San Diego. And I also, that's my daughter. I also, sorry for interrupting.
How are you? No interrupt. You want to come say hi? You want to tell everybody who you are? Okay.
Come say hi.
You want to say hi?
Hi. What's your name?
So are you gonna be a dentist someday too, or no?
Never.
What do you want to be? What do you want to do?
Zookeeper.
A zookeeper? That's a very cool job. Can I work for you?
Sure.
Sure. Right. I guess I've got a job right there. I'll be a zookeeper.
Sorry about that.
No, not at all. We'd love to. We want to see you. We want to see your life, and that's your life right there.
Well, it's true because it's been my life during the day like that as well. I'm taking consults, I'm homeschooling, I am having to work at home. My husband is working at home. We have my mother, she lives with us. So it's an intergenerational type of thing where my daughter is adjusting to the fact that now I'm here more often. And even if I close my door, sometimes she doesn't understand that it means I am with patients. So now I have to put a sign. And unfortunately, I failed to leave the sign on. So that's why she thought she could come in. Sorry. Thank you for understanding.
We're so happy to see her. So tell me, how is the health of the Hispanic population in the United States? What is the status? How is it different? Are there any differences in terms of the epidemiological studies, the results? I mean, tell me. We want to learn more about that, since that's the community you work with, right? Or you have worked.
I did not stay to the end of the study, so I was only part of the dental component until the sample number was completed. But I know that there were lots of differences. Some very positive information came out of the study. It was a very comprehensive study. It was about 8 hours of a series of intakes. It even included genetics. It included cardiovascular, physical activity, nutrition, mental health, so many things. And from that, some of the big learnings, there's a lot of disparities, unfortunately. There's a lot of risk factors that sometimes seem to have some strange kind of protection role, apparently, and some other factors that, of course, are very detrimental. One of the main learnings for me was the high incidence of sleep apnea in the Hispanic population. That was a lot of, there was a component that had a sleep study, and the numbers came up much higher than anyone had expected. And as you know, sleep disorders are related with cardiovascular, and it's going to have a lot of other overall health implications. In terms of teeth, the site that I was working at was San Diego. So this site was selected because of the high Mexican population. So I wouldn't be able to share much, but what I was able to see from the sample and the time that I was there was that there was unfortunately a lot of disease. We did not treat it we only screened and documented what we saw. A lot of issues with access to care. So we did referrals. That was one thing I did, of people that wouldn't know where to go and people that were not aware of the implication that an abscess or an infection of that kind could have for their overall health. A lot of periodontal disease, a lot of missing teeth. I think those are the main things that I can think of. A lot of root decay, because we also saw a lot of older adults.
Does economic status, is that an equalizer of all racial factors? Does that equalize it, or does it not equalize it?
Well, when you start looking at, like for instance, right now with the COVID-19 pandemic, when you start looking at which ones are the communities that are being affected the most, it starts to become very clear that those that are at a disadvantage end up paying the higher cost, because they are the ones with less access, they are the ones with less education, they are the ones that are having more limited income, they are the ones that are depending more on governmental support and programs. So when a pandemic like this comes, it doesn't distinguish on sociodemographics, income, zip codes, it doesn't matter, but unfortunately, those communities tend to live in certain groups, and that's when you start noticing some of those disparities.
And since you've been a dentist, since you've been practicing, have those disparities been ameliorated? Are things getting better? Are things the same? Are they getting worse? In your opinion, in your practice?
I think, in my opinion, they have been getting a little better. when I was working in the Hispanic community study, I saw things that were terrible. I come from the third world and I thought I've seen it all. And I remember this person, I've never forget, he had, I want to say maybe 28 teeth, and I'm going to say maybe late 40s. All his teeth were mobile. He would push them in and out with his tongue because of the advanced periodicity. And it was everywhere. That person, 40 something, 45, 47, was a denture case. So, but I think things have gotten better, to be honest. I mean, we're not quite there where ideally we should be, but at least here in California, we have some more benefits, and seniors or even young adults now can access some basic services. So overall, I would say it's been improving, but there's still a lot of work that could be done. I understand it's very difficult to provide so much for so many people, but then comes COVID-19 and forces us to rethink everything. And with the limited resources and with the limited access that we're gonna have and the limitations on aerosol that we're gonna have, I've started to think with my team, how are we gonna provide dentistry and what kind of new dentistry are we gonna be able to provide to our patients? And it's gonna be much more of the basic kind of dentistry, because with the population that we serve, that's gonna be what's gonna be best for them.
Now, I know that, you have a very, very impressive resume. You've served the underserved. You've done so much. But one of the things that I wanted to highlight is, I knew you were selected and you're an alumni of the Leadership and Diversity Institute of the American Dental Association. Can you tell me a little bit about what does that mean? How were you selected? And did it make an impact in your career?
Yes. I'm going to start by your last question. Yes, it did make an impact in my career, definitely. The process of how I got selected, when I got my license in 2007, I didn't have classmates here because I'm a foreign grad. So the next logical thing for me was to become a member of the Dental Society. So the very next day I got my license, I went there. I knew no one. I had no one, and I happened to be so lucky there was a leadership conference like 2 days after, and I showed up. And I arrived, didn't know anyone, but I knew then, I remember Carol Summerhays was greeting at the door. And she was the first person I met. And everybody seemed so friendly and so welcoming that for me, it became kind of like, this is a nice group to be in, and I like to be here. She suggested that I apply, and as well as Brian Shu, our editor here in the local dental society of facets. And they both thought that I would be a good candidate, that I should consider. They told me not to be discouraged because I would probably need to apply several times. Prior to having my dental license, I work in medical research, and I had done studies on pediatric obesity because I wanted to be a pediatric dentist, and I work at the pediatrics department. So I went with a project on childhood obesity prevention. When first I got accepted on the first try, and when I arrived, I remember, sorry, I think my phone is dying. I'm gonna charge the battery.
Take your time. Take your time. No rush.
Okay.
Take your time.
I was saying, I remember the first day, everybody was so accomplished. Everybody was so many things. And I was thinking, and I am here with a childhood obesity program. They made a mistake. I really thought like, wow. But it was so good because every single project that we did had so much value. It was the best money they could have invested, because that set a series of steps in motion. When I finished, I did my childhood obesity program, the HOPE program. It was a great experience. But when I finished the project, the program, what became clear to me was that I wanted to create a non-for-profit. And the rest is history.
Now, um, it appears that the leadership program had created a lot of opportunities for you and helped you solidify this vision. I think a lot of the members of the ADA will be watching this video, hopefully. As a dentist with such vast experience treating a minority community, which is growing significantly, and you and I both know that minority communities, especially in this COVID-19 scenario, the disparities are becoming more and more apparent. What could the ADA learn from IDL grads, and what could the ADA learn and can do better in terms of helping people like you succeed even further and getting your message out?
I think I represent community clinics. I represent public health. And I think for ADA, some of the things that I feel they could do better would be to establish a closer connection with those community programs, because it seems like it's completely separate. I happen to be a very active member of my local dental society, so that's why I will always be involved, but that's not the general rule. So what ADA could do, that's one of the things. I also think ADA could embrace change a little faster, in my opinion. Times are changing, the generations are changing, the demographics in the country are changing. Every 8 minutes, someone's turning 65 in this country. That is my area of expertise. So the more we can start working on how we are going to address those changes and the needs that we're gonna have in the next 10, 20 years, the better prepared we're gonna be. There's these disparities that I see are also affecting people at many different levels. When I see some of the seniors that I treat, not all of them are low income. Many of them had a very good life of good dental care, and after they turned 65, Medicare no longer covered dental. And then something catastrophic happened in their lives. Their wife got sick, their husband got sick, and all of a sudden, you start seeing a cascade of events that put a very good life of good dental care into a path of the perfect storm.
Now, you mentioned a lot about pediatric dentistry, childhood obesity. You wanted to be a pediatric dentist. Now, based on what I know of you, you've completely worked from one spectrum of age to a opposite spectrum completely. Now, tell me, how did you go from pedo to geriatric dentistry, if you want to call it? How did that happen?
Well, I didn't choose it. It chose me. I was on a single plane that failed mid-air, and I saw what I thought were the last minutes of my life. And at that time, I was ready to buy my private practice. And when we landed and I saw that I didn't die, that thought that I had from IDL on that nonprofit became stronger than ever. And I told Rob, you need to support me because this is what I want to do. So it was something that I wasn't looking for. Then I came back to San Diego and I met these wonderful, like-minded individuals that were thinking like me. And the rest is God put me in the right place at the right time with the right people that were thinking like me. And ever since then, we've been trying to make a difference. We're working on a solution that is going to help us all in the next 10 or 20 years. And that's the part that excites me the most about it.
You're obviously somebody with a lot of expertise in different communities and age groups. How is senior dental care or geriatric dental care, how is that different from other aspects of dentistry? What is this specialization? What does that look like?
It's a little more like special population care, if you want to call it, because it's a special care dentistry, to be honest. It requires more interdisciplinary approach. Some of the typical things that work for a younger adult may not necessarily be the same priorities that an older adult's gonna have. The crown doesn't need to look perfect. You just need to take care of functionality, take them out of pain, make sure that they don't have infection. You don't need to put them through so much, because sometimes that person may be very frail. Physically and physiologically, they may not tolerate as much stress, and they are not going to be able to bounce back the same way a pedo patient will do, or the same way a younger adult or an adult will do. So I think that the interdisciplinary approach, the patient care approach, whole person approach, is what makes the difference.
So I'm going to leave dentistry for 5 seconds. I'm going to ask you a interesting question. You're always a happy person. I've spoken to you, you know, multiple, it's like you can't stop smiling. So this is going to be an easy question for you. What makes you happy?
I thrive when people work together. That's what makes me the happiest. COVID-19 has been very hard for our team, for our patients, but I've seen so many amazing things happening in the community. People coming together on a time where we can all be lonely or alone in our own desk at home or wherever we are. But instead of staying there, people are reaching out, people are working from home, people are innovating, people are trying to bring different solutions. And that makes me very happy. Every day when I work with my team and we saw how we are thinking and how we are able to adjust and innovate, that makes me very happy. But in the end, I'm a people person, so teamwork is what makes me happy.
Now, going back to your practice, you talk about your team. You always, you know, the word you use is we. Who is we? And is your practice a private practice? Is it a nonprofit? What does that look like?
So I run a community dental clinic, which is a non-for-profit community clinic. Unlike private offices, our clinics are regulated by the Department of Public Health. So the private office typically are regulated by the Dental Board of California. The Department of Public Health is the organization that gives us our licenses, gives our annual permits. The dentists themselves have to be licensed by the Dental Board of California, but the clinic itself has to belong to that Department of Public Health. The team right now, it's hard times because the team had to be reduced. So we're less, and that was a very painful decision that I have to make, but it was what was right for the organization. We took it as a team with a team approach. We had to furlough some of our employees. Some of them had to go to 0 hours. Some others had to go to a little more hours. It was basically based on the business needs and what we were able to see during that time where we were not sure what was going to happen next. We have patient coordinators. We have full-time dentists. We have volunteers. We rely on volunteers a lot. We have specialists that are kind enough to give us some of their time and their skills, because those may be sometimes things that are beyond of what we feel capable of, comfortable doing. Who else is in our team? We have an operations manager. We have a programs manager, assistants, hygienists. We even have a prosthodontist part-time, because many of the seniors have very complex prosthetic needs. Particularly, the bread and butter is full dentures and partials. That's the team.
Did you find, were you the founder of this this clinic, this practice? Was it you?
I am a co-founder, correct. I was able to get support from the Gary and Mary West Foundation. So the foundation was able to give me the initial support and has been the one that has given the majority of support, because they are committed to help us find a solution that can be sustainable and can be shared with others, so that this problem that we're noticing here in California could be replicated anywhere else across the country, because the access issues that the seniors are experiencing here are not different than what other states of the country and other rural areas are experiencing. It's even harder when you go to a rural area. San Diego, it's considered an urban area, so it's a little bit better. It's worse when you are in a rural area and access to care is even more challenging.
So I have had the pleasure of speaking to a lot of students, that are about to graduate. And a lot of them, they've got student loans in the $300,000, $400,000, $500,000 range, and some even more. And some of them have mentioned to me that they're interested in potentially doing public health, just like what you're doing. What would you say to them?
I would say it's very rewarding. The one thing that I like the most about geriatric dentistry is that I don't have to push for anything that the patient doesn't need. I keep in mind what they need. I have to keep them safe at all times during the appointment. So it helps them regain their ability to eat, smile, speak, which I think are basic functions. So I get to give them back their dignity and their hope. So it's very rewarding. It can be very challenging too, but if anyone was considering something like this, I think it's a good opportunity. And I think as more and more people are gonna turn 65, if they don't want to consider geriatric dentistry, there's other areas like pediatric dentistry and working community clinics that it's also very rewarding. It makes you feel that you're giving back to your community. It makes you feel part of the community.
I know also that you've advocated with policymakers, legislators in the state of California for senior care. Can you tell us a little bit about that? And in addition, I feel that your cultural background, you being a foreign dentist, I feel that it is a strength in many respects because you understand your community better than a lot of people. Could you educate us on how that aspect of you have helped you in your fight for policy changes, or in how has it compromised you? Please.
The work that we have done, we were collecting the information and we want to show policymakers what that data is telling us and why it's a win-win to make an investment in this case. So I go there and I try to advocate for better rates, a little bit more coverage, because quite frankly, when I have to go through an appointment, it's a little more complex. I have to measure vitals. I have to review medications. My patients in average take 5 medications and they start having cognitive issues, memory issues. And I need to make sure that when I am gonna give them anything, they're gonna be safe and nothing's gonna happen to them. So just by going through all of that takes even longer. Then they have back pain, neck pain. I have to help them through the chair, accommodate. Then they cannot be completely reclined. They have cough, COPD. I have to let them cough. They can't stay so open so long. I have to give them that. They take a lot of diuretics, so they have to go to the bathroom very often. I have to do that bathroom break, and here we go again. So it's not necessarily the same as when you treat a younger adult. In a way, it's a little more complex care because you have to make sure that the patient's gonna be safe at all times, that they're gonna be able to respond and recover. So you're paying even more attention. I went to California I went to Sacramento to advocate for that. How my cultural background has helped me understand the issues. Well, when you're able to speak to the patient in the language they speak, in a way that it's easy for them to understand why that care needs to happen, I think that creates a connection and that creates a level of trust where people make a little more informed decisions because now they can comprehend those choices that you're giving them. informed consent. All of those things are difficult when you're speaking in a language that is not yours. When you can provide those services with a team that is multicultural and can speak the language that the patients do and can understand, because it's not just about speaking the language, it's understanding the culture as well. That is very beneficial. I know you have an Asian background, and I mentioned to you a couple of times, our downtown clinic has a lot of Mandarin speakers. And we had to learn that in the Asian culture, it's very important the respect that elders receive. So you have to be very mindful of that. You have to work with the team. We needed to find a dental hygienist that could be a Mandarin speaker, so we could address some of the cultural biases that patients may have when it comes to dental care. What else you said? So you said what other aspects of the cultural have become a barrier? I don't know. I can't think of one right now. I would say, of course, I know people say no, but I'm always super conscientious about my accent. And I try to enunciate the best way I can. When I have to go and speak in front of policymakers, that is terrifying. You may think that I'm doing okay, but I was very nervous. And I know that the more you do it, the more comfortable you get, but it's a big deal. So maybe because English is not my first language, that would also always be on the back of my mind.
I know this is your interview, but I'm going to give you a very interesting story. When I applied to undergrad at Tufts, the question that I had, one of my college essays was, by 2020, English may no longer be the majority speaking language in the United States. And how would you communicate with someone who does not speak English? And obviously they were referring to Spanish. And I see, I see a much larger population of Hispanic patients, and I truly enjoy the culture. And I agree with you 100% that when you understand the culture, it's not just the language, you're able to provide a much level of personal care, personal medicine to patients. So very impressed, so refreshing to hear your story. Is there anything that you want legislators, you want dentists, that you want the world to know about your work and your message that you would like to share as parting words?
Yeah, there's one thing. One of the things that always comes to mind is, depending on the audience that I am speaking, there's always this disconnect between medical and dental. When I talk to physicians, my biggest pet peeve is how the guidelines for endocarditis have changed, and sometimes the physicians are not educated on that, or how I have patients that have had total or full hip replacements, and those hips have cost a lot of money, pain, suffering, and yet when I look into their mouths, nobody put even $5 there, and that hip replacement may completely fail just because we are not looking or working together as it should be. I think when you're gonna put a hip replacement, somebody should look into that mouth and say, you need to go see your dentist and get clearance so we can take every single tooth that may be a potential source of infection. So that's a message for the medical community. For the dental community, I think it's time for us to think, how can we address some of the issues? We're not just working here. We need to measure vitals. In our clinic, we do A1C because we want to make sure that we are helping. So I think it goes both ways. Probably the biggest challenge, and this message would go to everyone, is the inability of our software and electronic health record systems to communicate easily. I think that's what makes it so complex, so difficult. When you manage for them to work well in the dental field, then they don't communicate really well with the medical field. Then they don't communicate really well with your medical device that is measuring blood pressure. It doesn't communicate so well with your intraoral camera that is taking the pictures. And I think the easier we can make all those systems be able to communicate and be interoperable, the better it would be, as we're going to have to face a lot of changes going together. As I was saying to someone yesterday, it's going to be a new kind of dentistry, and it's going to be a new kind of medicine going forward. It's a little bit of a welcome to a new brave world right now. I like being positive, so I'm going to say it's an opportunity for us to rethink how we're going to adjust and how are we going to recover from this.
Dr. Becerra, thank you very much for your time. And once again, it was very refreshing. And thank you for your work with Dental Cupid as well. We look forward to getting you back on in a couple of months' time and learning more from you. And someday we look forward to you becoming the next ADA president. So have a lovely night. And thank you very much for everything. Talk to you soon.
Thank you. Take care. Bye-bye.